Okay, well, let's go ahead and begin our meeting. We have a few members of the board who are virtual this morning. You know, probably 2.5 years ago, we couldn't have done this. This is quite the IT tech tour de force. I would ask all of us to be a little patient with the technology today. We're in a new room, new venue, and we're getting it set up for this location. I personally think this is going to be a great location for future Board of Health meetings. But there may be a few bobbles along the way, so just let's be patient to that. Special thanks to Jared Werner, Michelle Farley, and Victoria, of course, as always, for their help in getting this meeting together. So, and I'm going to rely on somebody to give me a heads up if there are hands raised from board members. I sure don't want to miss anybody. So let's go ahead and do the board member roll call. Doris, are you there?
Yes.
Doris Ralston?
Yes. Yes, I'm there.
Yes? Okay. Commissioner Cami Bremer?
I am present.
Turn your volume up just
Dr.
a little if you could. Commissioner Lojinos Gonzalez?
I'm here.
Councilmember Dave Donaldson? Here. Yeah. Our chief, Kate Coley? Here. And I'm Jim Turbush. I'm here, obviously. And let's approve the agenda. And you've had a chance to see the agenda. There were copies of the agenda out there, actually. I know all the board members have seen it in advance. Any comments or questions about the agenda today? Otherwise, I'd entertain a motion to approve.
So moved.
I move that we approve the agenda.
Okay, great. We have a second?
Second.
All in favor?
Aye.
Aye.
That's good. Okay. Well, let's do Board of Health comments. And these, I think, are particularly cogent. And I like the fact that we get to hear from board members. A lot perhaps has transpired in the last month. So let's go ahead and hear from Doris. Would you start, please?
Yes, I just want to applaud the health department staff, the team, and their partners for all that they've accomplished, and on behalf of our community's health.
Magicians in the back.
Absolutely.
Turn up the volume a little bit. Let's try again, and we want to hear what you have to say.
Okay. I just want to applaud the public health department staff and their partners for all that they do on behalf of our community's health. They are just amazing and relentless, and I appreciate them very much.
Thank you. Commissioner Cami Bremer.
Yes, thank you. I just wanted to say thank you for your patience with some of us being remote today. I am home with a kiddo home from school today, and for the first time in a long time, it's actually a traditional snow day and not school being called off for any other reason. So happy to be able to still join you and participate today, but thank you for your patience with my being remote.
That, of course. We have a little echo here in the room, so I'm not quite sure how to fix that. Commissioner Gonzalez,
All right, I think I'm sure it's going to come up later, but I'm very happy and pleased with all the great work being done and the data on our dashboard showing the very positive trends. Pray that it continues. I did want to highlight one other thing that has probably been making the news. This fentanyl abuse and overdose deaths are extremely concerning. I I know there's been discussions and efforts on changing some bills at the legislative effort, and I'm fully supportive of some of the changes that are recommended to reverse some of the bills passed last year. But this fentanyl abuse needs to be taken care of, needs to be addressed, and bills that would get rid of the fact that fentanyl is no longer a felony. I know this is not public health, but something's got to be done. Let's just say that to address that issue. And I think there are some bills this year that everybody needs to get behind. Thank you.
Gonzalez, thanks for those comments. It is public health, and we have a national level expert here in the community with Dr. Leon Kelly, our coroner, and maybe at a future Board of Health meeting, we might be able to hear from him on this most important subject. So thank you. Kari? No comment? Okay. Dr. Vu?
I have no comment.
No? Fire Chief Ted Colas?
No, I just echo the comments of the previous board members about the good work that's being done, and also applaud Commissioner Gonzalez for bringing up the fentanyl issue. It's definitely a concern for our community.
Absolutely. I have just a couple of things here. In the meeting today, our public health staff will be providing a summary of 2 years of effort in response to the COVID-19. And it's very encouraging to note that the numbers are falling fast. In fact, policy is stretched to keep up with data. And I just want to say how much I appreciate our public health staff, how hard they've worked for such a long time. You're going to hear this again, at least from me, and I hope at some future time we're going to be able to recognize a number of our public health staff individually for the very excellent work that they've done on behalf of our community. And I think it's time to begin transforming our approach to COVID. I think that, like many other locations in the United States, very many jurisdictions, if you will, have begun to rethink their approach to COVID, and also that it is going to be, and maybe already, part of our environment. It may be endemic, that is a regularly reoccurring seasonal viral illness that we've learned to live with, as opposed to a pandemic. So I think we can begin to, I'm not waving the checkered flag and say we're finished, but I think that it's important that we from this venue indicate that we are thinking transition in our policies and activities. And I want to also reemphasize the fact that public health has a lot to do. We've got a lot of usual activities that we did before COVID, and we're going to be reassuming a lot of those activities again very soon. And I think that's all I had to say.
Mr.
Oh,
President.
yes, one last thing. We met with Jim Reed, who's the head of the Pikes Peak Regional Office of Emergency Management, and had a very good meeting, Deanne and Doris and myself. And this close association between public health and public safety is particularly important to me, and demonstrates that a lot of our success through the pandemic has been through partnerships. So more on that, but we are exploring a closer relationship and perhaps some additional staff training and so on with the Office of Emergency Management. And now I really am done. Yes. Oh, I'm sorry. Go ahead. Okay.
Oh yeah, thank you, Mr. President. I would like to echo your thoughts of appreciation for the staff and their hard work over the last month, and also echo Commissioner Gonzalez's concern about the situation with fentanyl and the concern and desire that we do something about that and improve the situation for our citizens. And I also want to express appreciation to Deanne Ryberg, yourself, and the staff here for adjusting where we've been meeting and giving the citizens more access directly with us during the meetings, and also moving the citizen comment forward. All those things, I know it's really appreciated by the citizens. So thank you to everyone who's been part of making that happen.
Well, thank you, Councilmember Donaldson, and I appreciate those comments, and I didn't mean to skip over you. Thank you. And speaking of public comments, I think next on our agenda were public comments on items not scheduled on the agenda. And we have one gentleman who has signed up, and I think we have several in the room, obviously, but one who signed up previously and would like to make some comments. I believe Stephen Walsh, are you there on Teams? Oh, you're in person. Even better. Well, good. Yeah, come up and briefly introduce yourself and tell us if you're an El Paso County resident. That's important to me, at least, and any organization that you represent.
Yeah, that's great. Good morning. My name is Stephen Walsh. I am a proud resident of El Paso County, and I'm not speaking on behalf of any organization. I just want to start off by saying I do feel for you and the position that you now find yourself in. For 2 years, public health leaders have not discussed natural immunity, proven therapeutics, or the importance of early treatment. Instead, trusted leaders have thrown their credibility behind an ineffective, obsolete, and dangerous vaccine that does not even offer protection from transmission. The narrative is crumbling every single day, and leaders are desperately trying to keep it glued together. It is evident now that there is no public benefit to the continued vaccine push, and yet we continue to double down. There are over 1,000 studies showing that people are suffering life-altering reactions for a vaccine they may not even need. Recent military documents show a drastic spike in miscarriages, myocarditis, cancer diagnosis, Bell's palsy, and female infertility. There are NIH documents showing people are suffering immune damage from the vaccine, and there are numerous reports of people developing autoimmune disorders confirmed by immunity panel testing. New York Times recently reported that the CDC has been withholding data because the information could increase vaccine hesitancy. We can no longer pretend we don't know what's been happening. In the age of information, ignorance is a choice. It is far past time for this madness to end. Your fellow citizens are not only be affected physically, but also having their livelihoods being destroyed. Organizations are going off of your guidance. Your fellow citizens, myself included, are being fired from jobs and having unemployment benefits denied simply because they do not want to submit to an experimental therapy that they don't need after they have natural immunity from recovering from the virus. Additionally, I have had 2 immediate family members die alone in a hospital bed due to guidelines not based on science or human decency, only financial incentives. This is unacceptable and frankly un-American. We have all been lied to, manipulated with fraudulent data, coerced and abused over the past 2 years, and your decisions are directly impacting people's lives. Public health leaders have breached the public trust, and confidence in those actions are destroyed. Your credibility has been damaged, but you do have an option for redemption. You should withdraw your support from this experimental treatment that's called a vaccine. Every day, more and more people are waking up that they were defrauded, manipulated, coerced, and have done irreparable damage to themselves and their children. They will be looking for accountability. Unfortunately, the governor and CDPHE left you holding the bag, and I feel for you having to answer for those decisions that you've made, and I wish you the best of luck. Thanks.
Thank you for your comments. Appreciate it. Now, we have some members of the public in the back, I think. Anyone wish to make a comment, public comment? And you can decide the order. Please come on up. And anyone? No? Okay. Well, let's move to the next item on our agenda, and one of my favorites, which is the Public Health Champion Awards. And Deanne, could you? We have some here and some virtually, correct? Great. Thank you. Oh, sorry. Okay. Well, I'm glad you pointed that out to me. This is going to be kind of hard. Commissioner Bremer, please make your comment.
Dr. Turbish, would it be possible for whoever's running the running the AV part. When someone is presenting and speaking there at the podium or in the room, for the camera to be shown on that instead of the blank sliding.
I'll wait until the next meeting to be able to make that adjustment because I don't see a camera up here. Anybody in IT want to? Nope. Is
And
there?
no worries if you
Okay, we're
can't.
good.
I
I think we
appreciate
can
it.
do that. Commissioner Bremer, thank you.
Thank
And
you.
let me also ask, are there any other members of the public who wish to make comment who are not here in the room? Anyone remote, anyone on Teams? And this would be a good time. Okay, well, not hearing it at this point, we can come back also. We can circle back around and see if we do have some members of the public who would like to make comment. Okay. Deanne, welcome.
Thank you, Dr. Turbush. For our public health champions this morning, we'll be recognizing two partners. The first is Cindy Aubrey and the team from Pikes Peak United Way. So Cindy, if you'd like to come up. And while they're coming up to join us, I'd just like to share a few words about why we're recognizing Cindy and her team this morning. Cindy Aubrey is the president and CEO of Pikes Peak United Way, and she's here today with members of her team. It's the vision of Pikes Peak United Way through strengthened collaboration to achieve measurable improvements in education, income, stability, and health for residents of El Paso County and Teller communities. Very early in the COVID-19 response, Pikes Peak United Way collaborated with our agency and PPROEM to stand up their 211 line as the main COVID-19 resource coordination center in our county. 211 is a free and confidential referral hotline staffed by multilingual trained information specialists. In March 2020, Pikes Peak United Way call takers began serving as call navigators for El Paso County and Teller health departments, answering questions the public had in response to COVID-19. Between March and June 2020, their call center had helped more than 12,000 people in our communities. In addition to answering general questions related to COVID-19, the hotline was a valuable resource for community members who had questions regarding testing, guidance on how to protect themselves and their families from COVID, and also those who had needs such as food or mortgage or rental assistance, utility assistance, and mental health support. When vaccines became widely available in El Paso County in February 2021, Cindy and her team at Pikes Peak United Way and 211 again supported our community by setting up call centers to navigate and act as a resource hub for the community and talk to individuals in our community who had questions about whether or not they were eligible and where they could find a vaccine provider. During this time, Cindy personally came to the OEM call center and brought her family to help answer public phone calls in the first weeks of the COVID crisis and navigating those inquiries regarding vaccine. During the early stages of COVID, volunteer call center operators were growing very stressed by the volume and nature of the calls. Cindy Aubrey personally arranged for free counseling services to help us maintain the mental health of these hardworking community volunteers. Using the 211 call center for COVID and other disaster responses has gone above and beyond the MOU requirements of services and information available to the community. And this has been made available through our team at Pikes Peak United Way and under Cindy's leadership. For these efforts, we'd like to recognize Cindy Aubrey and the team at Pikes Peak United Way as dedicated public health partners and true public health champions.
Outstanding. Thank you.
Well, thank you so very much. I would like to introduce just a few members of our team today who we have with us. Chief Colas, I haven't seen you in a long time. Nice to see you. Heather Steinman, who is our Chief Operating Officer. Anjali Jean, who runs our Pikes Peak United Way 211 team. And Miriam Yost, who's kind of known as the Rod Smith of Pikes Peak United Way. So she's a great utility player. I will tell you, this is something COVID-19 has divided our community, has united our community, but it has been a privilege to work with El Paso County Public Health. And the partnerships that have been formed between public, private, healthcare, education, I mean, it's been remarkable to see the leadership in this community and everyone working as hard as they can. Public health employees, you have many, many fans in this community, and you are heroes to us. We're grateful to Susan Whelan and her team. We're grateful to all of the work that you do. And as I say, it's been an honor and a privilege to be able to work beside you. Our Pikes Peak United Way 211 team tripled because the call volume went up at one point 200%. And we did get calls ranging from requests for food, which we at that time established kind of a food train that would go out to people who could not leave their homes and were hungry. We had people who could not pick up prescriptions, elderly folks who had no transportation and no one to communicate with. We had people who called us, and thanks to the great training from public health, we were able to guide them to the vaccine locations, answer questions that were, within our scope. It's been a tremendous partnership, and thank you for this great honor. I don't know if anyone on our team would like to add to it, but you gave me way too much credit. It really is a team effort, and thank you, Deanne. But it's, gosh, it's such an honor to do this job, but wow, what an honor to be here today. So thank you all very much.
We're good?
They're all extroverts. So anyway, thank you again. Thank you.
Good job.
Dr. Terbush, could I, Dr. Terbush,
Yes.
could I make
Please.
a comment?
Yes, absolutely. Fire Chief.
Cindy, you pointed me out, so I'm going to point you out. Cindy and her team have been great advocates for our community for many years. The 211 network that you established gave voice to and a listening ear to all of our community, but to a segment of our community that's often overlooked. And I so much appreciate you looking at every single person in our community, recognizing their needs, and doing everything that you can within your scope of authority to care for those needs. Thank you so much to you and your team for everything you do.
Thank you, Chief. Appreciate it.
Well done. Any other board member comments? I'm looking for raised hands. Yes. Commissioner Gonzalez, please.
Thanks. I too just want to thank you for all the great work and feedback. But thank you and God bless. You know how much I appreciate all the great work that you and the teams have been doing for our community. God bless.
Thank you, sir. Anyone? Oh, Commissioner Bremer. Yeah, Bremer.
Yes, thank you. Cindy, I've said it before that we couldn't do what we do in government or in an organization like public health without the help of our nonprofit partners. And you have stepped up in such a major and unexpected way. And I am forever grateful to your entire team for taking care of our citizens when we couldn't do it alone. And you really stepped in and filled a huge gap, and you didn't even need to be told exactly where that gap was. You knew it because you're working with our community every day. And I'm just so grateful that you're getting this today. I'm very disappointed that I'm not there to hug you all in person, but greatly appreciate you and your entire team, Heather, Miriam, and so many others I know. Thank you very much from the bottom of my heart with a different hat on today.
Excellent. Any other comments? We had the blue screen of death there for a moment, but
May I just
We
say thank
recovered.
you to Commissioner Bremer and Commissioner Gonzalez. And we saw a lot of miracles in this community during COVID-19, and they saw them too. So thank you very much.
okay. Photo op, Michelle? Okay, please, go ahead and direct. Okay, I think board members, we get to gather perhaps on either side of them. Indiana. Get close to the middle. Move. Okay, here.
There we go. The queen of 2-on-1, everybody, right here.
All right.
Thank you.
Appreciate it. Okay, Deanna, I guess we have some more champions to recognize.
Yes. Our next partners that we'd like to recognize are joining us remotely this morning. So happy this morning to welcome our partners from Peakview Behavioral Health, as well as specifically Ty Meredith, who's the CEO at Peakview Behavioral Health. And this is a recognition that we had scheduled a few times and had to reschedule due to various conflicts and changes in the agenda. So we're so happy to have the opportunity to finally recognize our partners at Peakview. We want to recognize them today for their outstanding contributions to the COVID-19 response. Ty Meredith and her team were critical community partners in helping to connect patients to the right care at the right place at the right time during the COVID-19 response. Recognizing early in the pandemic the need to preserve hospital capacity as a critical component of protecting healthcare infrastructure, we worked with partners at Peakview Behavioral Health to identify ways to support safe and appropriate patient discharge when acute inpatient hospital care was no longer needed for these patients. Ty Meredith and her team played a vital role in supporting these efforts by bringing forward innovative solutions and resources to meet the needs of the community. Ty was a critical partner in crafting a unique model to help decompress hospitals by discharging COVID-19 positive patients who no longer needed the acute care resources of an inpatient hospital and take them to Peakview, creating a dedicated space to serve both the behavioral health and physical health needs of COVID-19 positive patients. Ty and her team quickly mobilized an entire ward at Peakview to serve patients with COVID-19, resulting in, to the best of our knowledge, the first such treatment ward within a behavioral health acute care setting in the state. Ty worked closely with our epidemiologists and our medical director on quarantine and isolation protocols that would facilitate the patient discharge from acute care settings to Peakview services. Through this initiative and countless other efforts, Ty and her staff have shown their dedication and passion to promote and protect community health. This is a testament to what can be achieved through innovation and cross-sector partnerships. It is our pleasure to honor Ty and her team at Peakview Behavioral Health as true public health champions. Ty, if you are available, we'd love to hear from you as well.
Good morning, everybody. I'm sorry. Can you guys hear me?
We can hear you, but there's a significant echo. So if you'll give us just a moment, we'll try to fix that as well.
Sounds good. 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 Sounds good.
Board member comments, and I'd like to start with the fact that Peak Vista has been a remarkable partner in almost every activity that public health is responsible for, and also particularly during the COVID-19 pandemic. It seems that the Peak Vista comes up all the time, and so we appreciate that partnership. Other Board of Health member comment? Any hands raised? Okay.
I'll echo
Yes,
what you
please.
said, Dr. Turbush, and it's just a continued testament to the partnerships that you're developing all over the community. And thanks to Peak Vista for sure. I mean, sorry.
I'm sorry.
Thank
Peak
you.
View Behavioral
Peak
Health.
View, not Peak Vista. Sorry.
That was my problem.
Thank you.
Okay.
And although our audio wasn't working, I just want to say thank you, Ty and the team at Peakview Behavioral Health. I know I saw you on camera earlier during the meeting, so thank you so much for joining us, and we look forward to working with you further in the future.
Thank you, public health. 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 Public health.
Excuse me, I'm Ty's assistant, and I am on Teams. And I know we talked about it yesterday, and she is very proud of the honor that you've given her and the hospital. We appreciate you and all the help that you've been to us during the COVID pandemic. And we look forward to working with you at length. And we want to thank you very much for this honor.
Number 6 on our agenda today is approval of minutes. The minutes were in the packets provided to all the Board of Health members, and so there's been an opportunity to review them. Any comments or changes on the minutes? Otherwise, I'd entertain a motion to approve.
Move to approve.
Do we have a second?
Second.
Okay, all in favor?
Aye.
Number 7 is finance and budget, and we have Samantha Montminy, and is she on Teams or in the room?
I am online.
Samantha?
I'm on Teams. Can you guys hear me? Good morning. Can anybody in the room hear me? Can we get the next slide? Okay. So this is your preliminary December financial information. Again, this is kind of the same story we've been hearing we've been telling you guys all year long. The revenues are down, however, expenditures are down, which is why the revenues are down for the year. Across the board, personnel is underspent. This is something that not only public health is seeing, we've seen across the board for the county as well. I know, just speaking anecdotally with other departments, so this is no surprise, operating's down. So overall, we're anticipating an actual increase to fund balance versus the original plan was to kind of decrease fund balance. So that is overall really good news. Do you guys have any questions on this preliminary December? No? Awesome. Okay. So there are 2 contracts up for you guys. I believe you have to vote on them. The first one is the El Paso County Public Health Sexually Transmitted Infection Education and Outreach Contract. This one is a new contract for public health for $35,000. Do you guys want to vote on these individually or at the same time? Because there's 2 of them.
Hi, Samantha. I am on Teams. I'm running the slides and I'm not in the room with them, but I think they're having some connectivity issues still, unfortunately.
Not a problem. Give them a minute. Right. Okay. So it sounds like they can hear me in the room, but we cannot hear them. So they are troubleshooting if we just give them just a moment.
Move to approve.
Second.
All in favor? 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 Okay, our second contract is for screening and treatment. And a little more explanation about that one, perhaps?
So the second contract is an ongoing.
I can read what it says here. This is a federally funded grant distributed the screening and treatment of patients infected with sexually transmitted diseases. All funds pay for lab fees and medications. And let me just say as an aside that during COVID, the last 2+ years, there's been a marked increase in sexually transmitted infections, and that our health department has been a locally recognized expert. In fact, we have providers from throughout the community that have in the past consulted with our subject matter experts. Quite helpful, actually. So it looks like that this contract is a one that we've had before, correct?
It does look that way, yeah.
Okay.
Yes.
So this is a renewal of a previous contract. Okay. Any questions from board members, comments? No? No? Are there any members of the public who wish to comment or on this particular topic? Okay, well then I would move to approve this, this contract.
So moved.
Second.
All in favor?
Aye.
Aye.
Okay. The next item on the agenda under new business is the Board of Health email policy. And Director Ian Ryberg, could you maybe give us a little background on where we are with this? I think this is the third time maybe we've visited this subject.
Certainly. The policy that we have under consideration today reflects the conversation we had at our last Board of Health meeting, in that we have set up a process where all incoming emails to boardofhealth@elpasoco.com are supported by IT to be automatically forwarded to all board members. So you should all be receiving all emails that come to that email address. We additionally have a member of our team assigned to monitor that email inbox. And when questions presented in that email inbox pertain to items such as programming, that we provide agendas that staff can reasonably respond to, we will work with our team, including Office of Communications and our administrative manager, to respond to those emails, while also including language in our response to reflect that answer being provided by our staff does not reflect the Board of Health, but is rather being provided by El Paso County Public Health staff, to help clarify that as well. And this policy should reflect the conversations that we've had over the last two meetings, as well as the processes that we have put in place. And I would welcome any questions or concerns that board members would have regarding this process.
And again, let me just add that during the director's report, it looks like there's some significant breakdown of the emails, the subjects, and analysis, which I think would be useful, and you'll have a chance to discuss that.
Yes,
Okay.
so we will continue to provide that in the director's report so that you will also be able to see monthly summaries of inquiries coming into the Board of Health inbox.
Okay. Questions, comments? Yes, Karen.
I have a couple of questions. I think it's working pretty well, but I wonder if there could just be a little more. I'm just still worried about the clarity in who's going to respond. Specifically, I'm thinking of the emails from the students that we got recently. They're not really commenting on policies or anything. They're asking us to help with their homework, basically. So maybe there could be if the administrative person monitoring could maybe tell us that they're going to respond, or I'm just for some clarity of, I mean, I know we eventually learn that, and I know you're still working it out, so I'm not trying to muddy the waters, but does that make sense?
I think with all new processes, there's a few things that we can work out as we proceed, and certainly willing to look at ways that we can embrace quality improvement, including this process. And I think that's reasonable, that if we know we are going to respond to this as staff and have content to provide, that we could let board members know we are working on a response. That seems like a reasonable adjustment we could make in our processes.
Yeah, there were two.
The other question I had was more for the board itself is, and it's just a question. I mean, I'm not suggesting any policy, but I responded to several of the emails and I copied Deanne on it, just because I felt like someone in the department should know what I'm saying. I am responding just as myself, not representing the whole board, but for transparency, et cetera. And I don't know if that's just, my own personal policy, or if we wanted to talk about that as a board of, we don't want to copy each other, obviously, because then that becomes like a meeting. But since this is new, that's just what I'm trying to work out, is how is this all going to look as we keep going, in the future.
Okay, well, the two student homework projects I addressed and am happy. I feel that's probably in my lane, being somewhat of an academic, and the questions revolved around the history of public health and environmental activities here in Colorado. The other one had to do with air quality issues, both good topics. And I think there's plenty of information available on that. I guess if we end up doing assisting students with their homework, that's okay if we have individual time to do it. But both good questions. Any other board member comments about the email policy?
No, I would just say to Kari that I think having the option to do that is good, and in some cases, you know, I would certainly do that. Other times, you might want privacy in the reply. And then sometimes what I've seen done also is, like in say the situation Dr. Turbush just explained, I have sent just a message out to all the other members. I'm thinking of stuff with the utilities board saying, hey, I've sent this to the billing department, just so everybody, you know, all 9 of us aren't trying to help out the students. Like if we know, hey, Dr. Turbush has it covered. So I don't know the exact steps we want to use to cover that. I just, and I do it. I guess I sent it to everyone else and told them I was doing it, but we could send it to Deanne, and then she could tell everybody, hey, Dr. Turbush is taking care of the students. So those are my thoughts.
I would just add that since the Board of Health email forwards to all board members, that is an option as well for ease, that if this is an email that you're responding to and you want to let other board members know, that's one way that could be accomplished, to just email that Board of Health email address, and then all board members will receive that.
Well, Councilmember Donaldson, I think it would be appropriate if individual board members who have a particular interest or background or specialty knowledge with regards the email question, go ahead and volunteer and address it directly. I think that's fine. Otherwise, I've been really quite pleased with the consolidated response from public health staff on all the issues I've had a chance to look at. Like I said, I think the students' questions were probably in my lane, and happy to do that. I think Commissioner Bremer, you have your hand up.
I do. I just wanted to thank Deanne and the staff for taking this project on. I do think we've made some huge steps towards transparency, and I know it's going to continue to bring up really good questions like Kari just brought up. But I trust this board to handle those as we can best collectively and individually. And I'm appreciative of the staff support on just putting the structure there that allows basically our citizens to know that when they've sent an email that it's something that we're seeing. So I know it wasn't an easy process to hash out, and I'm very, very impressed. I know we'll talk about it later in the director's report section, but very, very impressed with the detail on the last page, and I'm just grateful. Thank you.
Very good. Other board member comments about the Board of Health email policy? Yes,
if I could,
please.
Dr. Turbush, I would also just want to express my appreciation for the improvements in our email. I guess we can call it a policy, or just what happens when a citizen sends an email to the Board of Health now. I think it's just vastly superior to what was happening before. And now I'm actually proud when somebody asks me, if I send an email to the board, do you get it? I say absolutely 100% goes directly to all board members, and citizens appreciate that. So thank you for the changes.
Any other board member comment?
Yeah, I
This
just
might
wanted
be
to
an
thank staff.
opportunity for any members of the public who are here or online who wish to comment about the Board of Health email policy. Are there any members of the public who wish to comment? Yes, good morning. Please identify yourself and let us know if you're a resident of the county and if you're affiliated with any organization.
I'm Dr. Kent Robertson. I've been a resident of the county since '97, and I just represent myself.
Okay.
I really appreciate the changes in the email policy. for months and months. I've been sending stuff, not sure if anybody gets it. And in fact, some members responded to my last email. And as a citizen, that's really confidence building. So I very much appreciate it. And the responses I got were candid and useful. So good job.
That's great to know. Thank you. Anyone else? How about online? Any further comments on this subject?
I'm not sure if my audio is working. I just wanted to thank staff for the updates on this and Dave for bringing it to our attention. So thank you very much.
Great. Thank you, Commissioner. Any other comments? Okay. I think this is an action required item. It looks like it. And so I would entertain a motion to approve the email policy.
I move that we approve the email policy as stated in this document.
Second? Go ahead. Okay. All in favor?
Aye.
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 Okay. And we get to the director's report, which should be very fascinating and show some significant improvements in our county. Please, Director Ryberg.
Thank you. This morning, I'd like to just take a moment to start out with a little bit of where we have been over the last 2 years. If I could have the next slide, please. It's important for us to note that February 14th marked 2 full years of COVID response for our team here at El Paso County Public Health. In fact, February 14th, 2020 was the day we initiated our COVID-19 ICS, Incident Command Structure, to support our COVID-19 response. And our team at Public Health has been working tirelessly through that entire 2-year period in the COVID response. And I think this is a wonderful opportunity to just reflect where we have been, as well as appreciate the hard work of our staff and team through this entire 2-year period. Next slide, please. As we think about 2 years of continuous COVID response in El Paso County, I wanted to take a moment to share with you what 2 years of response has looked like for us by the numbers, so to speak. We have contributed over 1,560 media stories based on interviews and information provided by our El Paso County Public Health team. And this has been so important to us because as we moved into the COVID response at the beginning, we knew that one of the key elements of our response would be communication, as we were dealing with a novel virus for which we had very limited information at the beginning. So I want to recognize our communications team and their tremendous work to facilitate and support that high volume of media stories and interviews that were facilitated by our team. We also issued approximately 200 news releases throughout the response to provide the community with timely updates and information as we navigated this response. And in comparison, in a typical year, our agency would release approximately 10 news releases per year. So just reflecting on the amount of work that has gone into a coordinated community response. Also, we have increased our social media presence and using those additional social media platforms to communicate throughout the COVID response. And we have seen a tremendous increase in our followings on Facebook, Twitter, and Instagram as well. We routinely report and update to you regarding our disease metrics. We will have additional information from our public health data analytics team regarding that this morning. But on our COVID by the numbers, I'd like to point out the number of vaccine doses administered. We have had what I would say is a uniquely well-coordinated local vaccine consortium where we pull together vaccine providers, elected officials, community partners to plan for, facilitate, and communicate about how we would provide vaccines to the most populous county in Colorado. And you'll see those efforts reflecting more than 1 million doses administered throughout our vaccine consortium partners. And also, advocating for infrastructure within El Paso County so that we could provide testing to our residents, significantly supporting the COVID response. Our testing sites located throughout the county administered in conjunction with CDPHE, as well as the infrastructure brought forward by our community healthcare providers to administer more than 1 million tests in our community as well. So just wanted to take a moment as we talk about 2 years of response to reflect what that work has looked like and meant in our community. Next slide, please. So as we reflect on 2 years, as was hinted earlier, and as Fadi will go into more detail on our data metrics report, we are in a unique Board of Health meeting this morning in that we will be able to provide very positive information across all of our disease metrics that we track, and that is, after 2 years of continuous response, a really nice place for us to be able to bring forward such positive news. We are actively engaged in strategies to transition to a more routine disease response model for COVID-19. We'll see that reflected in some of the changes in our school guidance, as well as anticipating additional changes in public health guidance that will be coming from federal and state partners. We currently have high levels of population immunity when looking at infection-acquired and vaccine-acquired immunity. We anticipate expanded access to treatments and therapeutics in the coming months and widespread availability of vaccines and prevention measures, including partnering with the state health department to provide more rapid tests in our community as well. So with this next phase of our COVID response, we anticipate being able to move to a broader spectrum of our core public health activities, which, as you can imagine, the last 2 years, we've had to suspend some of our programming throughout these 2 years. We've had to ask staff to leave their typical responsibilities to support COVID-19 response. And looking forward, as we transition back to taking on a broader spectrum of our responsibilities, we will be able to focus more broadly, including focusing on statutorily required efforts such as our community health assessment and community health improvement plan that we'll share some information with you later in this presentation. However, with all of this good news, we don't want to lose sight that there's also still importance on our COVID prevention measures. And I would like to ask our medical director, Dr. Urbina, to speak to some of that, please.
Deanne, can you pull up that slide? Here we go. Good, thank you very much. Are you getting feedback from me at all? Or are we good? Somebody raise a hand. Great, thank you, Commissioner. I appreciate the thumbs up. So as Deanne talked about earlier, we're getting better, and I think it's tremendous that we collectively, with our community partners, healthcare systems, many of the people that were recognized as public health heroes earlier today, and our tremendous public health staff, we've really come a long way to make a difference. But we're not quite out of the woods yet, and if I can use that analogy. As we navigate this response, and Fadi will talk a little bit about the data and the decreasing number of cases, hospitalizations, and death, we still need to rely heavily on very safe vaccinations and boosters. And I recognize there's still doubt about the safety of vaccines and boosters. And so I spent a little time looking at the vaccine adverse events reporting system this morning. And as the speaker talked about earlier, there still are rare events, 3 to 7 rare events out of 1 million doses of vaccine, of Guillain-Barré, of thrombocytic purpura associated with low immune globulins, as well as myocarditis. When you compare that with the significant trauma related to having the infection, when you look at hospitalizations and death, the unvaccinated or less vaccinated folks are still represent, unfortunately, significantly larger numbers who are unvaccinated, who are hospitalized and death and have long-term consequences of COVID. So we still believe that vaccinations and boosters are safe. We also believe that wearing a mask in indoor settings, particularly if you're higher risk, people with chronic medical conditions or people elderly like myself over the age of 65, it's still important to wear a mask to reduce your risk. And of course, we still recommend people staying home when they're sick, because obviously whether or not it's COVID or mild infection, a respiratory infection or other illnesses, we still think people should continue to stay home if they're sick so they don't spread that infection to their workplace. There are, as Diane alluded to earlier, treatment and therapeutic options are present, as Dr. Vu will talk about, hopefully, and ask about. There are good treatments in the hospital. We have helped people survive COVID with oxygen, with steroids, with antivirals, with early use of medications. And so we're helping people survive COVID now in the hospital, and our healthcare systems have done tremendous work, and we'll continue to see improvements in treatment options in the future. And of course, as Mom always told me, you have to wash your hands. Continue to do that. I think that's still an important thing. And as we discovered, whether or not it's tuberculosis or COVID-19, increasing ventilation and airflow reduces the amount of viral load in our indoor settings. And so that's still important, whether or not it's in the schools or in our large office buildings as well. And I think in the bottom line, Deanne and commissioners, is that we encourage people to make informed decisions based on their personal health risk and factors. So as I alluded to earlier, as a 65-year-old guy, I'm going to continue to wear a mask indoors. And I would encourage my dad, who's 94, to wear a mask indoors with me if we go to restaurants, avoid large crowds, wash his hands frequently. There are ways to prevent ourselves from getting COVID or other respiratory infections, as well as protect ourselves from COVID-19. So I think I'm going to stop there, Deanne. I know Fadi has some great data to share with us, and I would be open to questions now or in the after Fadi's presentation. Thank you, Deanne.
Thank you, Dr. Urbina.
Let's go with Fadi and then we'll do questions.
All right.
Good morning,
We
everyone.
have Fadi to provide our data update.
Thank you, Deanna, and thank you, Dr. Urbina. Can you hear me? Perfect. Good morning, everyone. It's a pleasure to speak in front of you today, a day where we can deliver some good news. Typically, a data update in the past has often been synonymous with, here we go, very bad news. So it's good to be speaking on some definitely encouraging trends. Our incidence has been decreasing since the late January and definitely throughout the month of February. If you take a look at your screen, first, the graph at the bottom is showing you the deep decline that we've experienced. It's a response to the increase that we've seen in the late December, early January. We peaked on January 15th. We had a little bit over 1,800 cases a day for the 7-day average then. Now we're down to 118, a huge improvement. For the past 4 Tuesdays, as of last night's update, the numbers have basically halved. So starting on February 1st, it was 800 roughly, then to 400, then to 200, then to 100. Definitely encouraging, as Commissioner Gonzalez started the meeting with, definitely praying for continuing of this trend. Next slide, please. The decrease in the number of cases has resulted in a decrease in the number of hospitalizations. Yesterday, during the morning, our hospital partners came to an agreement to move the dial that represents the hospital capacity to green, indicating that their capacity is now normal. This is a change from 2 weeks ago where it was yellow, and 2 weeks prior to that, it was in the orange red. So the hospitalizations, our regional hospital data is showing similar patterns to our incidents. I'd just like to take this moment to send a huge shout out to our regional hospitals. They give us this data daily. And when the time comes for them to reconsider their capacity dial, they do so in a collective manner and allow us to present this data. Next slide, please. A little update into a monthly summary. January closed out with more cases than December, November, and October combined. We had roughly about 7 to 10 more admissions per day in January than the previous 3 months. And the deaths, while we did have our 4th month in a row of at least 100 deaths, it was less than the previous 3 months, and it was not proportional to the number of admissions and the number of cases. This reaffirms the early data that we saw nationally and internationally, and that Omicron was producing less deaths and less hospitalizations given the number of cases. February, given the incidence decline, has produced about 10 admissions per day, which would be less than the previous 4 months, and has produced, thankfully, a little less than 1 death per day. February is not done yet. Typically, admissions and deaths lag in data, but this is a very, 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 very encouraging sign in terms of serious illness data of the month of February. Next slide, please. This is a simple slide just to illustrate our conversation into thinking about the development and the response. As we move into a different phase of the response, we move into a different need and different strategy for presentation of data. One of the things that we'll be doing this week is updating our data dashboard to reflect that. On your screen, the graph to the left is the current landing page. And when I say landing page, I mean whenever people click on COVID-19 dashboard, the very first page they see is that metrics page where it displays the incidence and positivity. The graph on the right will be our new landing page. You'll be able to adjust the date range to any date range you like, all the way back to 2020. You'll see the number of cases, hospitalizations, and deaths adjust to the date range that you select. We'll also be keeping the rolling average for the cases so that you can view that in addition to the raw number of cases. This shift is to revisualize the data, reorder the data slides so that we move away from incidence and positivity because of the number of undetected cases and the rapid increase in the usage of at-home testing kits. The metric itself of incidence and test positivity loses a little bit of resolution. We're not taking away that page. It will just become the second page. And the landing page will become the graph on your right where it shows the cases, hospitalizations, and deaths. We call it the summary page, but it's sort of giving you the 3 factors that matter at this point. We'll also be taking away 2 pages in specific, the outbreaks page and the locations page, again, due to the decreased resolution in the number of cases and the significance of those pages losing its momentum as we move into the next phase of COVID response. They were more significant early on and sort of in the heat of the different variants. But as we move into this phase that we're in right now, whatever it may be called in the future, we don't think those pages are as relevant. We will continue to look to improve the dashboard in any way that we can and adjust to make it relevant. We will continue to update it daily during the weekdays, but we will not be updating it during the weekends or holidays. We have a streak of 680 days of continuous updates. To give you a little comparison, CDPHE dashboard stopped updating on weekends and holidays during the summer of 2021. We continue doing so, but now we are recognizing the need to shift to the next phase of data visualization. Data visualization in itself will become a huge part in our public health world, in Public Health 3.0. It's become sort of a baseline mandate for our clients, our citizens, in order to visualize data. So we'll be looking forward to incorporating data visualizations in many projects in the future. We'll be happy to take any recommendations, any requests regarding the dashboards. Sometimes we are not able to deliver on those because either the metric is not available to us or it's not a strong, stable metric.
Thank you, Fadi. Before we move on to the next portions of the director's report, I'd like to just pause here and see if there's any questions.
Let's do that because this is a real watershed moment. I think this is something we're going to be able to look back on and say today, here, this date with Fadi and Dr. Urbina, we really have turned the corner. So any questions or comments from board members, please? Yes, please.
I would just like to thank Fadi, and I love how we refer to him as Fadi, like, one name, Bono. I am not a numbers person, but I really do look forward to this part of the meeting. And I feel like he's really helped give clarity to everything that we're seeing in the newspapers, news media, that sort of thing. And it also tends to echo what I see reported at the hospital, at UC Health. But I even if we are changing how we look at the data, I hope we'll still have our Fadi report to us.
Dr. Turbush, if I may, thank you.
Other board member comments? Yes, please.
First, a question for Dr. Urbina. And I'll just look up, hopefully you can hear me.
Yes.
And Dr. Urbina, when you spoke about masks, you pointed out a couple times that, hey, I'm older and my father's in his 90s. We're going to continue to wear masks indoors. But it sounds like you're sort of walking back the recommendation for everyone to wear masks all the time in public settings indoors. First, is that generally what you're saying? And then second, should we then adjust our statement on the website, which I think is a more general, everyone should wear masks in accordance with the CDC guidelines?
Thank you, Commissioner. I'll leave the policy questions up to you and the board, as well as our director, Deanne Ryberg. But I think the evidence now is that we should all be encouraged to wear masks indoors, but it's a recommendation, not a requirement. And so I do think that what I was trying to get across with myself and my dad was try to evaluate your own risk. You know, if you have chronic medical conditions, you know, you're going into a large crowd, tight spaces, encouraging you to wear a mask is where we're at right now. And obviously, if you're unsure about the populations that are vaccinated or unvaccinated, it's probably prudent to go and continue to wear a mask indoors. But it's no longer a requirement. And I do think that the federal, Deanna alluded to this earlier, the CDC is likely to come out with some recommendations soon, as well as CDPHE, and we're certainly going to follow those recommendations. But I still think at this point, it's a recommendation based on risk. I hope that helps, Commissioner.
It does. And the reason I bring it up is because I've had some people come to me that their employer requires them to wear a mask at work based on either what our website says or the CDC website says. And just the reality of it is that even the city of Colorado Springs now no longer has that policy. County doesn't have it. So kind of the facts are moving, and our statement on our website might be a little bit behind that. So I would hope we can consider that a change to that, maybe even just with the language that Dr. Urbina used there, that take into consideration your own health status and consider wearing a mask when indoors or something like that versus a blanket, everyone should do this. And then one other question, this one would be for Fadi, and I'm happy to pause if anyone else wants to respond to that.
Well, I think at the end of the month, February 28th, our guidance is changing, correct? So we'll bring that up and describe it in just a minute.
Yes, specifically, school guidance will be updating, so we'll discuss that.
Okay, go ahead.
And then my question for Fadi is on the change in the landing page slide, what will the date range be set at when they land there? And the reason for my question is when people land on that page and they see 1,542 deaths, that's a frightening number. And if what we're recognizing is the risks are going down, we don't have to be, we're trying to kind of move back to a more normal atmosphere where this is endemic and not a pandemic. Perhaps we shouldn't have that big number up there right out of the gate, just like we don't have numbers of deaths from polio or something when you land there, because it's not the threat that it was in the past. And so I'll pause there, and maybe you can just explain that, if these numbers in the center of that slide will be there, or is that not the case?
Thank you for the question. So the date slider on the left-hand side of that graph allows folks to select any date range they want. We prefer that to rather than defaulting to say January 1st, 2022, because that may result in the opposite, in that folks want the different date range, the all-time numbers, and not recognizing the date slide is there. Perhaps we can make it bigger just to let folks know that they can select whatever date range they want, and the numbers will then adjust to that. So if someone selects January 1st, 2022, the deaths, hospitalizations, and cases will only reflect the data within that date range. We prefer to just let folks decide whatever date range they want rather than defaulting. We can definitely choose to default so that if someone lands on it, it's already pre-selected. However, again, that may have the opposite effect.
Thanks. And I'm not clear. when I click on this next week, are the numbers going to be there, or is it just there will be nothing and then I put some date range in, then I'll get the numbers?
It defaults into the all-time histogram and the all-time totals, and then you can select any date range you want, and you'll see it change to that date range.
All right. So my probably recommendation would be to have it at the previous week, over the last 7 days, what has happened. That's kind of a current sense of where we are with COVID today versus, again, the history. The deaths were much higher early on when no one was immunized, no one had natural immunity, et cetera. So, but I think I've kind of made my point on that. Perhaps once I'm done with this next question, we can, as a board, discuss if we think it should be set at 1 week or all time. And then I just didn't understand, Fadi, it sounds like we're going to drop some slides. We're just going to totally get rid of them. Which ones are those?
Yeah, the two important ones are the outbreak page and the location page. The outbreak page is data through CDPHE, and the data through CDPHE is still public. Anyone can access those. And the location page is where we display the number of cases per zip code over all time. Again, that's a little less significant and prevalent now with the decreased resolution into the cases. There are two other pages that offer aggregate information. That's the daily page where you can see cases, hospitalizations, deaths, and tests all on one. We're taking that away, but the information itself can still be accessed through other pages on the dashboard. And then finally, a secondary demographic page that we currently have called the trends, which shows age, ethnicity, and race over a time period. Again, that information can still be accessed through the demographic page. Right now, we're just presenting it through a secondary page in order to visualize it differently. We're taking that away in order to streamline and take away some of the duplication in the information presented.
Okay, thank you.
Any other board member questions or comments?
If you don't
Go
mind,
ahead,
to
please.
Mr. Donaldson's questions, I think I get what you're saying and what I'm hearing. So the slide on the left is what we've been watching, and we've been looking at the incidence and the positivity rate. But what I'm hearing is that we're not going to focus so much on that because the current variant Omicron or whatever we have going on isn't those numbers, because we're not below 100, we're not below 5%. And we're doing the same thing at the hospital. I asked about this. I'm like, so we're pretty much just ignoring these numbers, right? Because we're not at the numbers that we wanted to look at in the very beginning of all of this. So that's why we're moving away from that slide. So the question, I think, is what do we want people to focus on then? What is the information that they should get when they land on this page? And I think that's what you're asking basically. And is this the message we want to send?
All right. Generally, that's right. I understand that what used to be the first slide will now be the second slide, and we're going to flip that second one to first. And then my question and my thought for the board, maybe we can consider this, is do we want it, when they land there, do we want them to see 1,762 deaths? Kind of the shocker, or do we want them to see over the last week data? And they can adjust it out to maximum time if they want that big historical picture. I think most people are kind of concerned about what's going on now, not what happened 2 years ago or in the first 6 months of COVID, but what's going on today. And I think over the last week, perhaps the last month, but really even the last week, because things change so fast, especially with this Omicron variant, is probably a more useful bit of information to give them initially.
Right. My question is, what is it do we want people to focus on,
And I think perhaps another way that we could look at this, because one of the beauties of having the data dashboard available to the community is the opportunity to interact with the data. And that orange slider bar on the left side of the screen allows that self-selection of the data in terms of the time frame that somebody wants to look at. We could consider looking at labels that make it more apparent to the community that they can interact with that and select the data. I think when we land on this page, it may not be apparent to some people that they have the opportunity to interact with the data in that way. And I think as we look at this, the course of the last 2 years, that visual of where we've been and the steep decline in cases that we've seen recently adds some additional value as well. So perhaps a way that we can make it more accessible to the public, help them be able to utilize this to its fullest extent, is to perhaps look at labeling that data, the date selecting bar a little more clearly so people know that they can interact with it and interact with the data.
I like that idea that you label it clearly. And one of the thoughts that I had as you were speaking is maybe if we showed a high, low, and current, so that people, and a week at a time. So the high week historically, low week historically, and then where we are currently, then people can kind of gauge where we are with where we have been.
Oh, Dr. Amina, please.
Dr. Tribush, I think Fadi had his hand up first, but I would defer to him, and then I have a comment. Thank you.
I just wanted to clarify. So on the cases, hospitalizations, and deaths individual pages, we do offer that, Councilman Donaldson, a number for the last 7 days, last 14 days. What we could simply do is take advantage of the nice white space right below the cards, but above the graph, and have a second set of cards that displays the same numbers, but for the last 14 days, the last 7 days, last 28 days, whatever that may be. So that you can get both. You can get the aggregate and the most recent, and you still have the date range so that you can adjust if you only want 2021, for example.
Does that help, Commissioner? So
I think that would be fine. That would be useful. Again, but my concern is that people see, I see this on the nightly news too, is they always put up the total deaths, the total cases in the county. And so it looks pretty drastic when you see the total. But again, if we put up the total deaths from other diseases every night, it's pretty frightening. But if you look at what is happening currently, and that seems to be what we're discussing here, is we need to move to kind of an endemic status, kind of get back to normal. What's happening currently is the most important information. And so I guess I'm curious to see if there's other support to not have that as the first big thing. That's where people's eyeballs go, I would say. You go to that spike first, but then you look above it and you see this big number of deaths. I'm curious to hear other thoughts.
Commissioner Gonzalez.
Thank you. Yes, I was about to recommend the same thing. If we, I like consistency, so I like sticking to the original numbers that we've had, because I'm used to when we changed them up early last year, it confused me for a week. But I was going to recommend if we do the second slide is first slide, have either the top of this, have it split in half, the top of it be either the last 4 weeks or from January, and then under that, this current portion, so that again, you have, the first thing you look at is actually the current trends, which are very positive, but you also have, the trend from the beginning. I kind of agree. I don't know if I want to see this slide as our first slide unless it's split out like that, as was just recommended, I think, by 2 different people. Thanks.
Any other board member comments? Well, let me just comment on how useful the data dashboard has been. And I know when it was first introduced, it was very trend setting and became a best practice. And in fact, I know in other health departments and perhaps even CDPHE took notice of our data dashboard. So it has been quite useful all along. I look at it every day, and it's nice to be able to compare what I saw previously to what I'm seeing today. Additional information is a good thing. Making it user-friendly is a good thing. I think we have at least two SMEs up there, Dr. Bina and Fadi. What would be your recommendation to make this particular slide more user-friendly and informative?
I can start and then Dr. Urbina chime in. I definitely understand and hear Councilman Donaldson's comments. We too get frustrated by that as well, because what happened in 2020 may not be relevant to what's happening right now. It's part of the picture. It's definitely data that we want to look at. So I think sort of the best case scenario here would be to give both the last 7 days as well as the all-time aggregate, so that no one can say, you know, I want the whole picture or I want only a piece of the only the last recent data. So having both gives everyone what they need. This conversation is actually a good example of why we're so appreciative of all of you, because we are in this day to day. So sometimes it's hard to step back and look at it as a big picture. What do people want to see? So these type of this type of dialogue is extremely helpful for us to incorporate into the visualizations.
I agree with that, Dr. Turbush, and I do think these recommendations are solid, because obviously you're, as representatives of the public, you are looking at this very carefully, and we want to provide the best information possible for our public. One of the reasons, Commissioners and Dr. Turbush, why we talked about prevention strategies early on before the data was that I think we as residents of El Paso County, we as residents of Colorado, have a lot to do with where we're at. People have had previous infections that's contributed to our immunity. People have had vaccinations and boosters. People are taking precautions. And I think part of this update of the data is that we have control over how we go forward. The virus doesn't control us. Our behavior, our strategies, our mitigation strategies that we've implemented with our partners in our community have played a significant role in this changing picture of the data. So it's very important that we take home messages. We have control. The data is getting better, but we want to continue to do these strategies that we have control over, evaluating our own personal risk, moving forward. And so that just to say that we're done with this, the data is perfect, we're over COVID, is not enough, because all the things that we did and will continue to do are important, including vaccines and boosters. So thank you for allowing me to say that, Dr. Turbush.
I have one quick comment, which is it's great that we have this much data, and it's even better that individuals are able to use this data to help make good decisions. But one of the things I think we've left out in today's discussion is the importance of a relationship between a patient and their healthcare provider. And that particular nuanced relationship is terribly important, all the data notwithstanding. So Dr. Vu, I'm going to put you on the spot here just a little bit. I would ask that maybe you comment on the way that the data is presented and what additional benefit that provider-patient relationship provides.
Yes, I see both sides. I think it is important to know the current data. The current death is more important than the cumulative deaths over the last 2 years. Specifically, as was said, before immunization and before infection that offers natural immunity, the death rate might have been higher. And now with more people immunized and more people have been infected, have recovered, have natural immunity, the death rate likely is less. On the other hand, for me, seeing current data gives, interpreting the current data from the setting of previous data for comparison gives more of an idea, gives me more information than just seeing the current data by itself. So if we look at the bottom of the graph by itself, this current wave in relation to the previous waves and the trend of the current wave coming down compared to previous waves gives me more information than just focusing on just the current wave. So of all that said, I like Fadi's recommendation the best to have options and to show both current and retroactive data. And then of course the user has option to manipulate the data to see whichever trend the user chooses. I think patient-physician relationship is very, very important, like Dr. Tobush was saying. I think interpretation of data is one thing. Interpretation of the data is more important than just the raw data itself. And patients certainly have knowledge and expertise to interpret data. I think that interpretation of data has more value when patient and physician discuss and understand the value of the data. I think most, if not all, patients should understand, or would and probably should understand their physician's opinion. Patients and physicians don't need to agree on everything. The ultimate decision is made by the patients and not the physician. But if you trust your physician enough, you should take your physician's opinion into consideration. If you don't trust your physician, then that relationship is less valuable. Thank you.
I'm sorry, any other board members we haven't heard from on this particular subject? No. Okay, well, it sounds like we're headed toward a consensus, and if I could maybe restate it, is that more information is better than less. Having the individual be able to manipulate the data to look at the intervals is better, and to contrast the total number of deaths with what's happening in, say, the last week or so, it would be good to highlight that. So let me just propose with those 3 changes. Is there further discussion here at the table, or does that seem like a reasonable compromise? If I heard right, I think that's what Badi was saying.
Yeah, and
Yes?
Dr. Terbush,
We
if
have
I
a
may.
comment from someone in the room about that? I saw a hand raised. Yes, please. Come up and please let us know who you are and who you're with, and if you live in El Paso County.
Hi, I'm Maria Robertson.
Great. Please speak up.
I'm not real good with the graphs. Part of what I wonder when I hear reports on death rates is what is it compared to? What's the overall death rate? Is this what percentage? That helps me understand that if we're not just, to have something to compare it to. Does that make sense? My question, like to include on the chart the overall death rate in the hospital or in the county, not just particularly COVID?
Yeah,
to
we have much more detail than that, broken down by age range and so on. Dr. Vu, can you help us with that?
Yes, I agree that data is available on the website in other pages. Fadi, can you confirm that, please?
Yeah, the overall mortality data is available through CDPHE's COVID database. It's one of our future projects to bring that into, they show El Paso County, but we want to take a look at that and see how we can incorporate it locally here in terms of comparing the death rate to other things. In terms of hospital data, I don't think we would have access to that. This COVID relationship is unique and special, but I can't imagine having access to, say, all mortality data out of hospitals. I don't think any public health department would be able to do that. And if I may, Dr. Turbush, the next slide is just a real quick mock-up of what it would look like. Don't worry about the spacing or the aesthetics. We'll make sure that everything is spaced out correctly, but basically you'll have the cases, hospitalizations, and deaths, and then the equivalent of them, but for the last 14 days. Personally, I would recommend something longer than 7 days just because of the data lag in the hospitalizations and deaths as they come across our table.
Fadi, can I guess one option, if we would like to in order to more highlight the current numbers compared to the cumulative numbers, to put the second line data on top, and perhaps not necessarily put the cumulative data as a smaller font compared to the current data. That's an option.
Great suggestion. Simply done. We will do that.
Well, I've said it before and said it again. Your data and analytics department and the data dashboard have been a real godsend and an example to many, not only here in Colorado, but I think it's received some notoriety, if you will, beyond that. You're the subject matter experts. You know what the sense of the board is that we want it to be useful and available, and more information is better, and to highlight perhaps what's going on more recently in the last 2 weeks, say, than what has gone on total. So can we, and I'm trying to get a sense of the board here, can we leave this in your capable hands to come back with the product, and then we'll have a chance to look at it? Yes. The guidance. Okay, we've done that before. Okay. Go ahead.
I like these changes. Is it possible for us to for them to just go ahead and implement it in the next few days with our approval based on what we've discussed today?
Right. That makes sense.
Yes, our team has been working on an update, and with a few modifications that should be available shortly.
Then we can take a look at it. Okay, good. I think we have more of a director's report here. Please, CHA
Yes.
and CHIP.
Thank you, everyone. Before we go into that section, we do have an update on our school guidance from Haley Zachary, who is our communicable disease program manager.
Morning. Next slide, please. All right. So as Deanne mentioned, we are poised to update our school guidance. The CDPHE has determined as of February 11th that they are moving over to more of a routine disease control model within our schools. And so, Dr. Turbush, I know how much you like it when we lead the way. And this is actually really aligned with what we already have in place here in El Paso County and kind of have updated in December. So we'll look at a few of those changes in the next slide, but really this is moving away from kind of a heightened response to more of that routine disease transmission, where we work with our schools to kind of really balance, all the other issues that they have, and hopefully free up some more capacity for them to really focus on those other needs within the schools while keeping our schools a healthy place for students to learn and people to work. Next slide. So a lot of the things are staying the same from the guidance that we have already written and approved back in December. So the reporting requirements will be the same, meaning that schools continue to be required to report cases and outbreaks of COVID-19, as do other community providers. Isolation will remain the same, and it will remain a requirement, as will quarantine for household members. So this is really moving away not only in El Paso County, where we already have completed this, but also for the rest of Colorado. For traditional classroom exposures, quarantine will no longer be a requirement. There will be some specific scenarios where that may be a recommendation from the health department, specifically in outbreaks or perhaps classrooms where there is a heightened risk of severe infection, so a lot of our special needs classrooms. But that will be a conversation on a one-on-one basis. That won't be a blanket requirement. What's going to change is previously in our El Paso County guidance, we did require exposure notifications to go out to families in K through 12 settings. That is going to go away for individual cases. It is still going to be a recommendation as a best practice for those who wish to continue it, as it's a great way to communicate kind of what's happening within the school setting to parents in the community, but we will not require it any longer. And then case investigation and contact tracing will also be changing. In terms of that is going to come back under the umbrella of public health. We will work closely with our school partners, but it will no longer be a requirement of our school partners to do that on behalf of public health. So we anticipate that we will continue to have a really strong relationship with our school nurses and our school partners to work through kind of this next phase. But again, a lot of the burden that we have placed on our schools, who have really risen to the occasion and done a great job, will come back to public health, and we will support them in more of the traditional sense that we have previously. All of these changes will be effective on February 28th, which will give us a little more time to get lower in those numbers and come down in our incidence rates and our infection rates. So February 28th, but again, we don't anticipate that this will be too much of a shift for our partners, as they've already been doing a lot of it for the last month. So hopefully we will continue to decline and work through this next phase together. Any questions or concerns?
Questions for Haley? Any? How about online? Don't see any hands raised. Okay.
And before Haley leaves the podium, I just wanted to say that I'd like to recognize Haley and her team for their tremendous work. We just spent a fair amount of time discussing the data that we display publicly, and it is because of the hard work of our communicable disease epidemiologists, disease intervention specialists, and case investigators that we are able to share that richness of data with the community. So thank you, Haley, and your team for all the work you do.
That's great. Thank you.
And then next on our director's report, we wanted to spend some time discussing with you our community health assessment and community health improvement plan and some updates around those. As we discussed, having the capacity now to focus on a broader spectrum of our public health responsibilities. This is our opportunity to update you on some of the processes that help us establish that framework for our broader public health responsibilities. And with us today is Megan Haynes. Megan serves as our public health planner that supports these activities. And to many of you, she will be familiar for the number of years that she has reported to us on efforts around teen suicide prevention and her work leading those efforts. So thank you, Megan.
Quick question.
Just before you get going, is this the same or different from the community health needs assessment?
So the community health assessment is a process specific to public health, very similar to the community health needs assessment that our hospital partners engage in. So we'll touch on that.
Two different. Okay.
Yes, a little bit toward the end of the presentation.
Okay, thank you.
Great question. All right, well, good morning, everybody. As Deanne mentioned, I'm Megan Haynes, Public Health Planner for El Paso County Public Health. And I'm very excited to be with you today to talk a little bit more about our community health assessment and community health improvement planning processes. You may hear me refer to those as the CHA and the CHIP. We love a good acronym in public health. So I just wanted to provide that context before I hop in. We wanted to start by talking about our Healthy Community Collaborative, which is really the heart of our CHA and our CHIP work here at Public Health. This is a stakeholder group that has been meeting since 2011 to implement strategies that are identified in the Community Health Improvement Plan. This is truly a multi-sector collaborative. We have partners from schools, hospitals, health systems, nonprofit organizations, government agencies, interested citizens, among others, coming together to work through our community health assessment and community health improvement planning processes. The work of our community health improvement plan and the goals and objectives that we set in that is monitored through the Thriving Colorado dashboard, which is linked in this presentation. This is a wonderful tool for us that we've had in place since we began implementing our current CHIP. It is informed by our community partners that are doing work in our priority areas. It's publicly accessible, And so this has been a fantastic tool for us to track our progress related to our goal areas. I did want to mention, as we move toward updating our CHA and our CHIP, we will be working with data and analytics very closely on a data tracking mechanism similar to Thriving Colorado, but we're very excited to see how we might elevate some of that work, just making it, again, readily accessible and more impactful for our community and understanding how we're moving the mark related to the community's health. Next slide, please. So a little bit about the community health assessment process. This is something that's required every 5 years by the Colorado Public Health Act of 2008. It is also required for accreditation under the Public Health Accreditation Board. So as an accredited health department, we are required to engage in a community health assessment process. Both of these requirements recognize that this work requires community engagement and a collaborative process. So that is very central to this work, and that we demonstrate an enhancement of the community health assessment over time. So this is not necessarily something that we do once every 5 years that sits on a shelf, but that we're actively revisiting, reviewing, understanding the health of our community. The community health assessment does form the basis of the community health improvement plan, and it is framed around the Colorado Health Equity Model. So as we move toward updating it, that is the framework that we are working off of. This model was chosen by the Healthy Community Collaborative Steering Committee to ensure that we're really intentionally and thoughtfully reviewing all of the data on the factors that contribute to the health of our community. And so this is a different framework than we have used in the recent past with our last community health assessment. So we're very excited to be using that as part of our current process. Next slide, please.
Oh, quick question.
Oh,
go ahead.
Sorry, no,
Yeah.
quick question. What model did, if we didn't use that before, what did we use before?
So the previous community health assessment was framed around Colorado's 10 winnable battles. And so you'll see shades of that in this framework that we're using now. It's just presented in a different way to also include some other things around the social determinants of health. So we see a lot of the same health behaviors, health conditions that are in that framework, just presented in a slightly different way. Great question. So moving now to the community health improvement plan, like the community health assessment, this is required again every 5 years by the Colorado Public Health Act of 2008, and also as part of our accreditation process. And again, this is really a community collaborative process intended to track our implementation and revise it over time if necessary. And so we do this work in partnership with the Healthy Community Collaborative and other community partners. That's how we find that engagement and that collaboration. Our current community health improvement plan takes us through the end of this year. So it began implementation in 2018. It takes us through the end of 2022. And it has 2 goal areas, the first of which is addressing mental health and substance use, and the second of which is improving healthy eating and active living. And so those are the current goals of our current plan. Next slide, please. And as I've alluded to, we are actively in the process of updating our community health assessment to inform the next community health improvement plan. On the slide here, you'll see there are 8 phases to this process that takes us both through the CHA and the CHIP. We are currently in phase 3, so conducting a community health assessment. And what that really means is bringing data to the community through the Healthy Community Collaborative to discuss it, to understand it, contribute to the process. There's a lot of back and forth dialogue about the health indicators that are brought forward as part of this process. Our data and analytics team are the ones that compile the available data and brings it forward for conversation in our monthly meetings. This is where I would like to mention that that team is absolutely integral to this process. We could not do this work without them. It is so fantastic that we have built the capacity of that office over the last number of years. And so I'm just eternally grateful for Fadi, Coulter, the other folks in the office for contributing to that process. A strong community health improvement plan can be used by other agencies in our community to identify local health needs and priorities. So it's certainly what we're identifying as issues in our community, but it's something that our partners can pick up and point to as well in terms of aligning the work that they do. We use the information from the CHA and the CHIP to find alignment with partners like our hospital partners and through their community health needs assessment processes. They are on a 3-year cycle for planning for their processes. We're on a 5-year cycle. And so we are hoping in time to find strategic alignment around those timelines. We were hopeful that we might have been as we were coming up through this planning process, but with COVID, we hit some timing snags, obviously. That said, we've already started planting the seeds and having some conversations about how we might approach that in our next plan. So it is something that takes a lot of time and intentional effort. And so we'll be looking to do that as we move toward not our current cycle that we're approaching, but the following one. A little bit about how we find that alignment currently. For instance, I've been working closely with Centura. They are working through their community health and needs assessment process right now. We've done some very intentional sharing of data and our processes to ensure that we're on the same page as it relates to understanding our community's health, that we're reporting on similar indicators and metrics so that we're finding that intentional alignment and supporting each other in those processes. And so truly, in bringing this to you today, we wanted to raise some awareness of the exciting work that's being done. This return to more routine activities is, I think, certainly welcome and, as I said, very exciting. And we're really looking forward to digging in, getting through this year, working on the community health assessment and putting together this community health improvement plan. And then I look forward to bringing it back to you all at a future meeting to demonstrate where we have landed in terms of what we've decided our priorities and what we hope to tackle in the next 5 years. And so that is all I have today. And I would be happy to answer any questions if there are any.
Thanks, Megan. Questions from board members? Comments? Yes, please.
I would just like to thank you for this. And this is getting back to what the fundamentals of public health, which is exciting to be seeing and doing. And I'll just point out that we had, during this whole COVID time, we had a lot of people coming to us. Why aren't we focusing on eating well and, those kind of individual behaviors? And we do. This is what public health does. So I'm glad to see us being able to get back to the building blocks of what it is we actually do as a public health agency. Thank you, Megan.
Thank you.
Other board member comments? Yes, please. Councilmember Donaldson.
Megan?
Yes.
My apologies, I wasn't in the room when you first started, but can you just go into a little more on what actually makes up conduct a community health assessment? Are we measuring like tangible metrics? Is it a discussion with neighborhoods?
Right. So excellent question. I realize when I say conduct a community health assessment, that's a rather nebulous statement. But certainly a big part of it is looking at a set of health indicators at the community or population level to understand the health of the community. For us, because we've chosen to frame it around the Colorado Health Equity Model, that is going to include things around economic opportunity, the physical environment, the built environment, health behaviors and conditions, mental health, and access and utilization and quality of care in our community. And so CDPHE provides some of those data indicators as a starting point. They provide that to all local public health agencies across Colorado as we all engage in this process. But this is where data and analytics has been so key. They are part of every discussion that I have planning for every meeting when we bring this content forward to the Healthy Community Collaborative. They're looking at available indicators for each of those areas that I mentioned. And so they reference a number of secondary data resources to provide that content. We are also investigating an opportunity to do some more primary data collection, qualitative data collection as part of our community health assessment. This would be one of the first opportunities that we've had to do that as part of a community health assessment. And really that is due to some COVID-19 related funding that we've secured And recognizing that COVID-19 has certainly had impact on the health of the community and wanting to understand more from citizens directly, how would you report your health? What are your top health concerns? Things like that. And so we're exploring opportunities to include that as part of our community health assessment so that we're not just relying on secondary data sources, but leveraging some primary data collection as well to help flesh out that community health assessment. So there are quantitative data aspects, there are qualitative data aspects. It's really open to what we have time, resource, and capacity for. There's not a lot of prescriptive guidance around what all needs to be included in a community health assessment, but certainly best practices and things that we're choosing to do.
And did, Mr. Johnson, did you hear her mention the HCC with the 60 members? Maybe you missed that part of it. Maybe just reiterate.
Sure. And so we do have the Healthy Community Collaborative, which is a stakeholder group that helps inform the community health assessment and community health improvement plan. So those partner agencies as well provide data and feedback on the process. They are informing it so that it's not fully driven and determined by public health, but it is done in conjunction with the community.
Okay. I'm not sure if other board members would be interested, but I would be interested in just having a little more of the information on what goes into the community health assessment. It sounds like you kind of have a framework and you'll kind of choose what to put in there. Dr. Turbush is really the expert on this. It sounds like we really couldn't use this to compare ourselves to another community because we're going to choose our own things to measure ourselves on. Is that correct?
I would say to a certain extent, yes, because each community has the latitude to determine what ultimately is part of their community health assessment. There will be some areas in which we can draw those comparisons based on the subject area, right? And so I do think that has been a goal of CDPHE in providing some of those population level health indicators. They do have a database or a dashboard that allows you to look at that by county as kind of a level setting opportunity. But you are correct in that it's not necessarily lending very well to a one-to-one comparison.
Megan, these are both the CHA and the CHIP required by Colorado statute.
Correct.
So we do it under the guidelines and with the framework provided by the state health department and actually by law. I was in this room not too long ago. I guess it was pre-COVID, so that was a while ago. And the members of the Healthy Community Collaborative, it seemed like we had almost 200 people in here in this very room. I know we don't have that many individual organizations perhaps, but it's a very collaborative, collegial, and useful process trying to get the most input for what we can do to best improve the health of the county. I liked it.
Okay.
Thank you for your presentation. Any other comments? Any other hands raised for Megan? Thank you. Great presentation.
Thank you.
Appreciate it. Okay, yeah.
That we have this morning for the director's report. But before we conclude, I would just like to one more time thank our team, Jared Werner from our deputy PIO, as well as Christian Wright, who's from the county's team, who have been troubleshooting this new location, the new systems for us today. I understand that there was a reset of the IT, the Wi-Fi here in this building last night to problem solve some Wi-Fi issues, and that caused a reset of some of the settings. So they have been in real time navigating this for us. So thank you so much, Christian and Jared, for all your work to support this today.
Yes, echo that. Good job, IT. Also, I wanted to again recognize our public health champions, Pikes Peak United Way and Peak View Behavioral Health. Thanks for your assistance and collaboration. This is a good time to see if there are any other comments from board members or members of the public. Any final comments? Not? Oh, yes, sir. Please. Yeah, let us know again, please, your name.
I'm Dr. Kent Roberson, been a citizen of the county for 20 plus years. And I have one quick thing that I'd like the board to consider. I appreciate all that was done today. It was a very good meeting. Thank you. Last week, Dr. Herlihy, the state epidemiologist, presented information and data suggesting that 90% of the Colorado population had immunity either from the mRNA shots or from natural immunity. The Colorado Department of Public Health then re-looked at their emergency rule that they enacted in August, which I applauded that. However, they fell short of the current data on the benefits of natural immunity. I think I'd like the El Paso County Board of Health to consider a statement regarding natural immunity, because what's happened is a lot of healthcare workers have declined or chosen not to get the mRNA shot and have lost their jobs. These people are out of work because of the Colorado Department of Health's mandate. The changes that I understand were made in that emergency ruling fell short of the segregation that's currently taking place, and people are without jobs. I know numerous healthcare professionals are without jobs. Healthcare facilities are reporting burnouts and taxing of their staff, and it seems like one solution is to have better understanding of natural immunity in the emergency rule or get rid of the emergency rule. And I know that's not El Paso County Board of Health's issue, but as the most populous county in the state, I think a statement, or I don't know if you have contacts with the Colorado Department of Health board, but encouraging looking at the worldwide and US data on natural immunity. In fact, there's good data from UK and Israel that those who had the mRNA shot had higher rates of infection in the Omicron variant than those who had natural immunity. If that is accurate, then the current mindset of, well, we have to test those who don't have their shots or aren't fully given their shots because we have to protect the patients, it seems the reverse might be true, is in fact those who have had the mRNA shots actually are putting our people in facilities at higher risk if the UK data and the Israel data is accurate. So my encouragement is for the board and get data from Department of Health staff members as to where we're at with natural immunity and really address that as a board. I think the medical and social segregation is unnecessary.
Thank you for your comments. You know, there's a lot in there to unpack. Board member
I would like to
Kilroy,
address just
please.
one thing, not the, I understand what you're saying about natural versus the vaccination immunity. But, and I understand the correlation you're trying to make between healthcare workers leaving because they are required to have vaccinations. And I'd like to debunk that a little bit, if you would. With UC Health, we have over 26,000 employees and less than 0.1% left. And so I don't think that's a right correlation to make in your argument, just for future.
Thank you.
Okay, thank you. Any other raised hands, comments, rebuttals? Yes, ma'am.
Hello, thank you for allowing me to speak. My name is Andrea Roberson. I'm a member of this county for 25 years. I think that you're all doing a great job with the tools in your toolbox that you've been given and that you have trusted. And I ask you to suspend your belief in just momentarily and imagine if possibly the tools in our toolbox that we've been given of the PCR test, the vaccine, and are brought to us by the CDC, NIH, NIH, and FDA, and pharmaceutical companies. They have a lot of money invested in these things to the tune of $128 million a day this past year in revenue. And that equals in 8 days over $1 billion every 8 days. And the article I have here is documents with footnotes that the 2021 death rate is up across the board in all areas of death, all forms of death, and insurance payouts for disabilities and death, like whole life insurance, are feeling the hit. The insurance companies are feeling a hit, and their actuaries do numbers that if there's a 10% rise is factored in for the possibility of rise in death in a period of possibility over 200 years. It's very unusual. And yet in 2021, the year of the vaccine.
Let's go ahead and bring that to a conclusion.
The year of the vaccine is death rates up 40% this past year, with a less, the Omicron being less of a threat than COVID. And so look at death rates overall being up in 2021 by 40%, according to insurance companies, whole life insurance companies, as well as like people, the undertakers that are doing the death counts. And that we might have a bigger problem with the vaccines causing a lower immune response and uptake in cancers. And look at that, because I know you guys have good hearts and you want to do your best, and you're doing a great job with what you believe in. I would like you to consider questioning some of the things you believe in. I believed them with you for a year. I was right sitting where you were sitting and in agreement with you 100%. And I want to warn you to reevaluate. And thank you for your time.
Okay, thanks for your comments. Thanks for coming in today on this cold day. I think this venue is good. And I think the IT department has done a remarkable job on short notice. So I would ask board members, maybe if you think this is good, or if you think that we could make some changes to this venue that would be improved, why don't you drop a note to Director Ryberg and we can evaluate. Okay, without any further comment, this meeting is adjourned.
Hi, thank you.